Good morning, everyone, and thank you for joining us in this session. Dr. Kelly has requested that the questions be sent in the chat throughout the talk, and then our volunteer, Roberta, will read these questions aloud. Towards the end of the session, Roberta will be sending links for Breakout Session 2. These links are the same that were provided in the schedule sent to you via email, but just so you have them at your disposal. Dr. Richard Kelly is professor in otolaryngology, ears, nose, throat, or ENT, specializing in voice and throat disorders at Upstate Medical University in Syracuse, New York. Over 10 years ago, he traveled to Ethiopia and discovered the extreme lack of services and care for people with ear disease and hearing loss. Since then, he has sought to educate and foster healthcare provider supply needs and coordinate with other agencies to support the development of the ENT training programs. The successes, pitfalls, and limitations of international healthcare mission work are the focus of his contributions to the American Academy of Otolaryngology International Humanitarian Committee, of which he is a current member. He received his medical training at SUNY Syracuse and received his medical degree at Stanford University. Dr. Kelly received both undergraduate and graduate degrees from Tufts University. Dr. Kelly, please take it away.
Thanks, Nadia. I appreciate the opportunity to speak today as part of this Health Justice Conference in 2022. Unfortunately, it'd be great if we could have face-to-face. That was the plan. Unfortunately, with everything going on, we're going to deal with this, and I'll do my best to keep you all engaged. So the topic, advanced goals for medical missions to Ethiopia, and a little side note, advocating for health justice abroad. So when we think about health justice and what's the tie-in with medical missions, I guess the questions you kind of have to ask are, are these medical missions attempting to achieve or promote equal access for affordable quality care from the community? And particularly with international medical missions, is there a way to advocate for these changes? So it's pretty typical, as medical students, a large amount of this audience is like, well, we'd like to do a medical mission. And there's certainly increasing demand within medical schools and even residencies for people who have this experience. A recent study indicated 2 out of 3 matriculating medical students wanted to experience or participate in one. But a lot of these are, participant focused is sort of the education and training from the medical students. But there is a sense of, medical service and social responsibility, which is great. And for international and even national medical missions, there's a little element of tourism as well. But typically, the outcomes will be listed as case studies or reflections of, what their experience was. There'll be pictures. We've had within our academy for ENT, there are grants and residents will go on missions. And typically there'll be a couple of pictures of what we did and our experience and 2 or 3 paragraphs that are submitted and placed in a bulletin or something. And these go on year after year. But, let's talk about medical missions. The history of them really dates back to the mid-1800s or so. Typically, these were accompanied by attempts for, religious and colonization efforts. The Red Cross was introduced in the mid-1800s, followed by Red Crescent. These are more of a secular approach. You leap forward 100 years, the World Health Organization in the 1950s or so was organized, as well as many non-government organizations that followed, as well as universities, such as Johns Hopkins and Harvard and Michigan, and several others that really had a footprint in different hospitals and regions within Africa, very parallel to colonization attempts 100 years earlier. And again, these are popular because of the introduction of vaccines, antibiotics, and more concern about public health. In the 1970s and 80s, the amount of medical missions increased because of the ease of air travel and the increased awareness with the use of the internet. And just a general idea of like, let's do good and feel better in the process, whether it's a religious or secular organization that was setting these medical missions forward. And Africa represents 17% of the world's population, but less than 1% of the world's wealth. And so unfortunately, there's no end of the need. And since they need us more than ever, it's pretty easy to justify trying to put together a medical mission. However, there is a downside to the way things were typically structured 10 years ago. There's potential to undermine the long-term community efforts, releasing the government from the responsibility to develop a good healthcare program. There's potentially, with a medical mission, sidelining local health providers. It may cultivate negative sentiment. If a team comes in, they do work for a week, they leave, and what they leave behind may be, a need for wound care or problems or infections. And then there's also the potential for getting a dependency on these medical teams to come in every 6 months, once a year, every few months or so. And they're also plagued by typically a lack of follow-up for the work that they've done. Certainly in the past 10 years, this has been recognized, and there's sort of this list of worst practices, surgical safaris with really no local involvement. The team would just sort of show up and work in a particular location. The top-down approach, where you may raise a bunch of money, give it to the government, but then because of corruption, material never, is squandered, doesn't get down to where it's really needed at the community level. The use of expired medications and materials that are kind of brought into suitcases, but inappropriate. You have volunteers who are enthusiastic but untrained. And then again, these short-term interventions are repeatedly cited in the past 10 years as not being the best way to do things. So here's an example. If you Google, which I did a couple of days ago, medical missions, again, well-meaning people. But here we have the classic, Facebook page where, have the white people looking down at a glowing orb, which presumably is in the operating room. And then, they're trying to have their family picture and trying to fundraise. And they sort of like highlight the fact that they were trying to raise supporters, within the Facebook community to sort of get money so they can go and do good and heal and provide hope and everything else. I guess the question is that really, what they're able to accomplish? I mean, are they really providing hope? Certainly not in the grand scheme of attaining health justice for these locations. Here's another one from out of Los Angeles, a group which really lists it as, the underserved third world country of Ethiopia, which is a little bit derogatory and a little bit outdated. Testing their skills. Here's this huge group of people raising lots of money to go there. And they were working in a private hospital. They had select surgical cases that they took care of. And yet they went back to Los Angeles. They were on local television. They got a lot of notoriety for their efforts. So really, who is benefiting most out of this proposition? And one last example, the Starkey Story. Well, this is a hearing aid company out of Minnesota that does a lot of good, does a lot of fundraising, but their experience in Ethiopia, going back about, I think it was around 2014, is that they solicited people to go out into the communities without any hearing testing, without any ear exam, but to ask who had a hearing loss. And they would fit these putty ear moles for about 3,000, and they had a minimum of 3,000 people that they had to have ear moles. The Starkey plane and helicopters flew in on a weekend. They set up tents. They dispensed the hearing aids with a pack of batteries. When I was there years later, we would still have people with broken hearing aids, people that had run out of batteries 2 years ago, someone who had bought this on a market or something. So the whole idea of what good was there. And I'm not sure if this is the case in this story. And I do know that Starkey has gone back again, and now do have an office in Ethiopia. But certainly there's a question with some companies where they will dump their products that are no longer viable in the marketplace in the West, and you get this huge tax write-off. So in terms of corporations, it's kind of a mixed bag. Sometimes there's good, sometimes it's, again, beneficial to them as the primary winners. So a traditional medical mission, again, in general, it doesn't really advance health equity. But there's been recognition of this in the past few years. Publications that cite that now you really should have volunteers that are prepared, really have a sense of the cultural awareness and humility when they're going to these countries, that you absolutely should partner with local organizations, that there should be adequate supervision if students are involved, looking out for volunteer safety, ethical patient care. And again, when you go to these places, the diseases are typically far advanced. There's other issues of, nutritional problems, and certainly a lack of supplies. And so you really have a whole host of other ethical issues that are raised that need to be sort of addressed even before you go. This is one of my favorite ones just from last year, which is a survey done to foreign teams. In other words, places where teams were going to, and they asked the host what was most valuable. And this is sort of my sense is on the bottom here, facilitating teaching of local staff was by far what they felt was most valuable. And so again, when you have teams that go in with all, Western surgeons and scrub techs and nurses and anesthesiologists, you're really, generally not focused on training people there. And so for them to attain, a sense of health, justice, or equity, or going along that road just isn't there. So let me talk about my path, and I'm not immune from this. I'll start with that. In 2009, my wife and I decided to adopt a child, and turned out that Ethiopia was where we decided to do that. So having been there in 2009, before then I was sitting in a Weiss Cotton Hall and Googling Ethiopia and medical trips and adoption, and turned out that this person from Stanford, where I got to medical school, had been to Ethiopia. So I contacted him. He put me in touch with 2 ear, nose, and throat doctors in Addis Ababa. So upon arriving there, jet lagged and feeling horribly tired, we drove around and we went to the meat district and had, where the freshest raw camel meat was hanging on the wall. And we went through a meal and saw their clinic, saw their hospital. So after that experience, I immediately signed up to do a medical mission to go back and to do good. It was with Wide Horizons for Children out of Boston. And essentially, didn't know it at the time, but I was basically taking the blue pill, the whole blue and red, the whole matrix, which is sort of been revised now. So what was my experience? Well, let's talk about Ethiopia first. Well, it's a fascinating country. It is where the theory is from your old history books, where we all started, and humans developed in the Rift Valley, and then from there migrated all over the world. Currently, it's 115 million people, which means it's the 12th most populous country in the world, the 2nd most populous in Africa next to Nigeria. It is the birthplace of coffee. It's the land of runners like Haile Selassie, who has multiple world records for long distance running. Unfortunately, it's also known for famines back in the 80s with Live Aid, and then in the 70s prior to that. And these famines have also gone along with a lot of political change from Haile Selassie, who was there from the turn of the century through World War II, with Africa being invited to the League of Nations. He was overthrown in 74, thought to be due to a famine, and his insensitivity to that. Soviet-backed regime took in place until 91, but in the 80s there was famine and again unrest. So there's a long history of that, unfortunately. Our Marley, and actually we think of Jamaica, but it's actually tied into Shemi, which is an area in mid-Ethiopia. But Ethiopia has all this tremendous potential. It has enough farmland to actually feed all of Africa. Unfortunately, now all the land is owned by the government. They're leasing it to farmers that then export grain out to India. And also they're building a Renaissance dam, which has enough electricity that should be able to power all of Africa. So just a fascinating country. Just a few more things. Again, it is landlocked. It is in the eastern part of Africa, the sub-Saharan part. It is the Rift Valley runs right through it with a highlands on the western part, a desert on the eastern, but right through the middle is a lot of lush green lake-like wonderful area for coffee growing. This is a picture on the left from the highlands. Again, I would encourage everyone when the opportunity comes to visit this country. And on the east, again, very lush fake palm trees and fake banana trees called insets. A lot of their nutrition comes from a root-based plant growth. The big exports are coffee, obviously, and cat, which is a great Scrabble word that doesn't require a U. But this woman on the left, she's got this big pocket of green leaf that she's chewing on, and pretty much it has this effect of cocaine mixed with adrenaline or something. So never drive at night in Ethiopia because all the truck drivers chew chat. We go on. It's a huge amount of building. Their growth over the past decade has been over 10% growth per GDP per year, and yet it remains the 170th in the list in terms of poverty. It's bustling with people, but they're very warm and welcoming people. Again, injera on the left is a type of spongy flatbread that you peel off and eat with your right hand, and most of the foods or vegetables or meats are basically stew-like. And coffee ceremonies are ubiquitous within the country. Here on the right, we're basically in the operating room. They have an open fire where they're basically boiling coffee for a departing ceremony. You too can have experience with these foods there's 2 Ethiopian restaurants in town, one on North State Street, one on North Slime Street. So I would encourage everyone to get out there and try this very unique food. But let's get back to healthcare statistics going back to 2009. At the time, again, they're near the bottom in terms of the World Health Organization in terms of infant deaths being 78 per thousand, maternal deaths about 14%, life expectancy only in the 50s. Immunizations were lacking, and the primary issues then were HIV, malaria, and TB. Fast forward 12 years, the biggest concerns are still malnutrition, TB, and malaria. So despite Bill and Melinda Gates providing lots of condoms and lots of counseling regarding family control and population control, HIV has been reduced. Unfortunately, the other 2 areas are still primary problems. So not on the list of big issues, is hearing. So here's my team, 2009. Oh, this looks like a lot of the teams that I just criticized. Well, it's true. Here we had some white people that were going to Africa with the idea like we go to this remote district hospital in southern Ethiopia with a team of the 5 of us. And they said, sure, come along. We've done this before. This is our 5th or 6th trip, but you're interested, and so it's all good. But don't be disappointed if only you see 5 people, because there's really no problems with ear, nose, and throat disease in Ethiopia that we've seen. So it's a long travel day. Back in the day, you take a Boeing 767 out of Dulles, you refuel in Rome, and by the time you get there with an 8-hour time shift, it would be 7 in the morning when you arrive. You feel like it's midnight. Going through customs at the time was kind of a joke, because you could take all of your suitcases and they would manually push them through the X-ray machine because it doesn't work. And so there's this facade of actually having a customs program, but didn't exist. It's far, far different now. The currency at the time was the birr, which is a 17-to-1 ratio. Currently, it's 49-to-1. Their last year, they had a 19% inflation rate. So one of the things we can talk maybe later about in terms of health justice is really the idea of inflation, money, the unbanked, blockchain. All of these things are technical things, technology advances that really could make an impact, whether it starts from healthcare and percolates all down to the population and increase wealth and opportunity for the population. We get to this hospital, which was built in the 1950s or so by the Netherlands. The grounds look great on the outside, the inside, not so much. A clinic would open the next morning, and much to their surprise, they made a radio announcement, and 250 people showed up.
Dr. Kelly, I think you've become muted.
Where are we at, Nadia?
We're all set, yep.
Okay. So the team itself was a bit annoyed that there was 250 people and families, and when you have a person or a patient, typically the whole family would come, and they had no place to stay. There's no hotel, so people were sort of all over the grounds. Therefore, there's a security problem. Therefore, the hospital was a bit annoyed too. But you can see that at 8 a.m., the windows open. There's all this paper charts. If you look, for some reason it's not advancing. Here we go. On the left is a lab where just kids are walking around barefoot. In the middle, it looks like an old organic chemistry lab with toluene and benzene and all these carcinogenic type products on the shelf. On the right is a group of people that are waiting because you have to buy everything. So if you have a family member, you have to buy the IV fluid, you have to buy any bandages, you have to pay for everything in advance. And the family members are ones that are primary caretakers. There really aren't a lot of nurses. And of course, in the bottom right is the X-ray machine that hasn't worked in about 2 years or so. So it's quite eye-opening. But we did have a clinic, and here are my numbers. We're there to teach, and we got students. The good thing is in Ethiopia, math and science beyond 4th grade are taught in English, and medical school is taught in English. So talking to students that happened to be there was fine. There was no issue with that at all. But of the people that we saw, it was quite alarming and quite surprising that virtually all of them had ear problems, draining ears and hearing loss. So part of the trip was also to go in the OR. But again, this is sort of a side effect of the fact that they've had not only American teams, but teams from other countries that have been there on this routine. So here you have in the top left, surgical instruments that are just sitting there. My patient needing an ear surgery, waiting out in the hallway by themselves. The OR was empty. The windows are open. The flies are there. The monkeys are running along the roof, making it sound like there's a thunderstorm outside. And yet we're the staff that is supposed to be helping. Well, they were all enjoying some injera and Buna on the bottom right, because they assume like when medical teams come from the West, they just check out. This is a downside and one of the problems with medical missions and how they were set up. So there I was doing my ear surgery, big deal. So there's a long flight back, and pretty much, stewardess might have said, "Oh, would you like a drink with that red pill?" So I took the red pill and took a little reality check and just saying, well, there's really no awareness of ear disease in this country, certainly beyond the few ENT doctors that existed, but only in the main capital city of Addis. There's a lack of medications. I would bring a whole bunch. I gave out about a whole bunch, disappeared the first morning. Then beyond that, they would say, write a prescription. Well, after we were done writing about 100 prescriptions, it turns out that there's really none of that medicine in the pharmacy. There's lack of clinic space, lack of follow-up. You can read the list. And then one of the big issues was they brought up a whole garbage bag of beanie babies. So the whole focus became, rather than worrying about getting an ear check, was to bother people to try to get a beanie baby, because it was just became kind of silly at the end of this trip. So again, looking back at that time, an assessment, well, there were 8 ENT doctors in the city. Only 2 of them did ear surgery, but only a private hospital. There was really no access for anyone in the country, except if you were politically connected or wealthy, in which case you would basically leave the country, go to Germany or go to the West to have your family member or yourself taken care of. So there was just starting a residency program in ENT at the time. 10 were in early training, but there's only 2 instructors, and neither one of them did anything with ear surgery. People would potentially finish a residency only having done 8 or 9 surgeries, compared to what we do in our program, which is about an average of 1,400 surgeries, including ear surgery. At the time, the World Health Organization was aware of ear disease, but it was a low priority. They did have a pamphlet, which you get a copy of, which only described basically wicking the ear and getting the moisture out. There's really nothing else beyond that that they were offering for people to do. So in terms of what was the healthcare on the ground, there were healthcare providers that were some medical doctors with no formal training, and health extension workers. And at the time, there was a big push in the Millennium Program to train 30,000 to 40,000 women who would live in the community, again, mostly based on maternal fetal issues, but an opportunity for potentially to have them trained at least basics around ear disease. They're very rare otoscopes. Medical schools did not have otoscopes in their clinic. There were only 4 or 5 microscopes within the whole country. And again, the formulary, which you have to adhere to the Ethiopian formulary for medications, was what we would expect in 1975 or so. There are no training programs for audiology, for hearing testing. There are no hearing booths, with the exception of the 2 private ear doctors in the country. So in the grand scheme of that, what was the role? What could I do that would be of any good? Well, first would be to sort of delineate what the incidence of ear disease and call it attention to the Ministry of Health. The only study was done in Kenya, indicating about a 4.2 incidence of chronic ear disease, which in Ethiopia would translate to about 3 to 4 million people. And also to identify the consequences of a hearing loss. So I met with the National Association for the Deaf in Ethiopia. And we talked about the consequences being limited education. So typically people with a hearing loss might be dismissed after third grade or fourth grade or so. There's no typical way you'd make it into university. Although later we learned that there was people at the university and they were interested in getting a screening hearing for university students. But there's problems with getting employability. There's also a social stigma with having a stinky, draining ear. And also some people think there's evil spirits, and families were shunned for having someone with, particularly with deafness. So again, what can we do aside from increasing, maybe doing a study, maybe getting some local grants? Well, the idea was there were other Americans, there were other international groups that were working there. So, let's get a curriculum within their medical school to talk about it. Let's offer a clinic. Let's sort of, get things going there. Again, just for comparison to time, you had 3 to 4 million people with hearing loss, only 10 doctors. So that's 1 per 8 million people or so, compared to the US, where there's just lots of money and expense. And known, cost of hearing loss in America is estimated at the time, $56 billion in terms of lost productivity, et cetera. So again, in a country like Ethiopia, certainly it would be significant. So we would focus, this is version 1.5 of a medical trip. And I went on the second trip in 2010. The focus was to go to a health college. So Awassa is in the south, located near that first district hospital. But we went there with the intention of potentially having a clinic and surgery, but really focused on giving lectures. We coordinated, and I called a place called Dr. Mum's otoscopes, these AA batteries otoscopes that you could buy, designed for mums and dads here to look at their kids' ear and save them a trip to the urgent care. But, we got a boatload of them. We brought them, we donated them to medical students. We did clinics in terms of ear exam diagnosis and cures and potential treatments. And the idea would be that we maybe would start with ear surgery with just the basic repair, because most of what we saw were eardrums with holes in them. And so a tympanoplasty is basically repairing a hole in an eardrum. Try to get a dry ear. Maybe not correct the hearing loss, but it might, but try to get a dry ear. So I coordinated with Christian Blind Mission out of Germany and met with one of the people who had been working in the country, as well as Eardrop from the Netherlands, which is a program that also worked. And again, they would go in twice a year, they would do surgery, they would see certain people, but they would disappear for 6 months. They were really working out of one site. So again, that was not going to lead to any great change in the country. But they had a similar program, so why not partner with them? So again, we wanted to also establish mechanisms of having ongoing supplies. So again, what I did is I set up and got a 501c3, which is established out of Virginia because New York is a pain in the butt to try to do that. And then I would drive around and call around all over central New York, down to Binghamton, Horseheads, and up to Watertown, and pick up ENT equipment and store it places, and then go to the good people like Macintosh Pallet out in East Syracuse, and they would crate this stuff up and have to go through the logistics of potentially shipping it there. But most of it was brought, maximizing your 2 suitcases of 50 pounds and getting it through customs with pre-approval to bring this equipment in. And so in addition to the medical trips, I was going back and forth with adoption type trips, numbering about 9 and 3 years. So each time I would go, I would meet and bring equipment and give a lecture in addition to the adoption side of things. So the idea was we wanted to sort of set up hearing clinics, at a hub type pattern at different regions of the country. And one of the things that I was clueless about is thinking like Ethiopians are all pretty much the same skin color. They're all must be pretty much on equal footing. And yet there's a huge ethnic and ethnicity problem, which sort of stems from the way things were governmentally organized, which is only now unwinding with a lot of chaos in Ethiopia, unfortunately. But certainly there was a lot of discrimination based on ethnicity and where you're from in Ethiopia. Again, a lot of the money going to the north into Addis Ababa itself, and very little money trickling down to hospitals in other regions of the country. One of the other things we talked about, in addition to expanding to these other regions, was to look at telemedicine. So I tried that. I worked with Johns Hopkins. Total disaster, total waste of time, never got off the ground. And even now, I imagine it probably would not work out so well, just with the government control of telecommunications there. So let's move on. A huge turning point happened in 2011. At that point, Addis Ababa had started an ENT program, but they were only in their second year of a 4 to 5 year training program. But there were 2 graduates who had finished, gone on to a residency program in Egypt, which is only an observership. They did not let them touch a patient. They did not do any surgery during their time there. And yet they were back in Ethiopia wondering what the heck they should do with this limited training. So I got in hold and in contact with them through the first ENT doctor, Dr. Naga, who's a wonderful person. And so I met these 2 people and we said, okay, I'm going to focus on training you. We're going to outfit you. We're going to empower you. One will be located in the north, one will be located in the south. And I work with Dr. Mulliken in the south in Awassa, that same hospital that I've been giving lectures at. So we had a joint understanding. There's this need for the 2 ENT doctors to be successful. So we had to educate them, supply them with materials, have sustained support over years. We would give them surgical skills, and each time we would go, we would pick the most basic surgery, then build on that and just more and more advanced, but over a period of time. We would donation furnish their clinic. Now I'm out private and public because they are expected to work in the private. They only make $250 a month as a salaried physician there. So the reality is, if you want them to stay in country, you have to give them an opportunity to have a private setup parallel to their public setup. So it's duplication and yet necessary. So people there work very hard. They'll see the typical workload that we have, but then after dinner, they'll have a clinic at night and then they'll operate on the weekends. And this is the way it is for 50 out of 52 weeks a year. They need to be able to live in the country. Otherwise, it's a great fear of immigration. And Ethiopia is known for that problem. And I'll talk about that hopefully in a second more. We need to replenish things. Things break. Light bulbs burn out, batteries run out. So we have to be able to replenish their supplies, advocate for them doing additional fellowship, not just relying on us, but to go cross-border, which again, the government was very reluctant to have them do. And in time, that these 2 people, North and South, would establish their own residency training programs. So again, I highlighted the location because it's fairly important. Addis Ababa is in the central part of the country by design. Mekelle is up in the north. Awassa here is in the south. But other trips, when we were going on these and supporting them, I would venture out to Harar, which is in the east, which is predominantly Muslim, but very fascinating area. And Bardar, which is where Lake Tana is, which is the Blue Nile, which feeds into the Nile, which again, these are all different ethnic areas of the country. So we want to sort of like see if we can work north, south, and then branch out to east and west. So the resources, now fast forward a couple of years, is that, well, they had graduates that were now coming out. Hospital administration, again, there's a huge boom of doctors, and doctors then became hospital administrators. So they were actually former classmates of the ENT doctors that we were training. So it's a great advantage to work with hospital administration. The Ministry of Health was now taking notice of this. And the resources from elsewhere were my group, which is Partners for Global Hearing, Global ENT Outreach out of Seattle, Healing the Children out of Philadelphia, the Ethio-American Hearing Project out of Chicago, Global Christian Blind Mission, the Eardrop Foundation, and then surgeons or individuals that would come on our trips and then maintain interest in working from Israel, India, Italy, England, and the Americans. So again, subsequent to this is the whole idea is like we would have recent graduates, we have to work with them in a similar fashion to empower them by training instruments, giving supplies, then having them host a team to come because that really elevated their stature within the hospital. So trips 7 and 8, we also did this new model, which is a boot camp, a surgical boot camp. So you can see in the bottom right, well, again, not standards of Western medicine, but we would have 2 simultaneous surgeries. These are typically done under general anesthesia in America, but there they insisted that they can do it under local. So these are complex 2 to 3 hour ear surgeries done under local by 2 teams. And you can see these are the Ethiopian doctors that day after day, 8 cases a day, 5 days, a huge learning experience for them, all arranged by the people from Christian Blind Mission, because this was their private clinic. But it was a great model to really ramp up their training. The last couple of trips that we did was again to Mekelle, and there's also a St. Paul's, which started a residency program in the country with someone that we had previously trained. Bardar in the West, which again, someone that we had previously trained and had come to America, and then Gondor. Now, another way to empower them was to bring them here. Now, there's our American Academy, which has these visiting scholar programs and a humanitarian board. So I would put in and they would apply, and thankfully 4 of them were awarded this award. 3 were able to attend. The last one, because of President Trump, cut down visas, and so he was not able to attend in 2017. But prior to that, we had people coming. And I did have, through connections in Virginia, the former ambassador who warned me quite sternly that you do not want to bring an Ethiopian doctor to America, because in the 90s and early 2000s, there's a huge brain drain from Ethiopia, where lots of doctors would leave the country because there just wasn't any great training. And once they had a medical school certificate, they would apply elsewhere and end up in America. So he said, if you bring them here, they will jump off their visa. And so I'm very proud to say that that never happened, and they had a great experience. We would host those doctors here when they would go back to country, and we would do a medical mission. Typically, there's inevitably the first day, there's a TV crew there. So it would improve their morale, their prestige. They were given more OR time, more resources, the fact that they were doing this, all as part of this, bring them here, to highlight as well as the learning experience that they had here. And again, here's some pictures of Dr. Mulliken back in 2011 with Bethlehem, my daughter, who has actually attended her baptism. On the right is Dr. Yilkow in 2014 or so. And he's always amazed, and even to this day, we'll talk about that October day where we were watching this game called lacrosse, and it was sunny out, and yet it actually started snowing, and it was bitterly cold, and he could not believe why people would live in central New York. And I think we all still wonder why some of us still live in central New York. Dr. Aznat came, and here he is getting his award in the top right, and outside of our upstate down the bottom right. And again, doing a dissection we had arranged for him, as well as going to the OR and lectures and giving lecture and meeting people at Syracuse University as well. We kind of maximized their trips here. So version 2.0, medical trips in the last 3 to 4 years, our responsibility was to have a small team, be nimble, furnish all the needed materials for the medical trip, obtain our Ethiopian medical license, which was new, obtain a business visa, which is a hassle, cover all of our costs. And again, cumulative over a decade, I think the total amount of costs that we expended on these trips was probably less than $100,000 compared to other single medical trips, which are known to be $200,000 or more. Their responsibility is to secure time and space within the operating room, arrange country transport, in-country lodging, which took the burden off of us, pre-screen patients to be efficient, arrange to have maximal education experience for other residents to come from the main capital, Addis, or other residency programs to attend these trips and observe all of this work going on. Again, joint responsibilities, we're both setting up the goals for the trip, which surgery, so we're going to learn, what techniques, we're going to educate the staff together while we're there, we're going to be exemplary, work tirelessly, and identify next goals and have a debriefing and follow-up. Again, several publications have been obtained by ENT doctors in the Western R journals. And again, they will need to continue to foster education in their programs and training and access. They will train mid-level providers. They will educate the public. They will work with their other specialties within the hospital to highlight, what ear disease looks like and how to be taken care of. And again, the idea is they're expanding the reach and access for people with hearing problems and ear disease. Now, we're also encouraging independents. We're getting them to seek grants and get, instrument grants from Karl Sortze out of Germany, which they have successfully done, and continue to seek that they are able to travel out of the country, be paid for, given a leave to do these things. And so, meanwhile, we're advancing the state of the art in terms of treatment, in terms of implants like cochlear implants, which have now been done in the country, bone anchored ear procedures. Again, so these are more contemporary pictures of us going there and a couple of white faces in the crowd of other people there. But there's always going to be obstacles. This is the most recent trip where we sent things in advance. Unfortunately, it was put in a storage locker with this huge lock made in China. And the only thing we could find was a dull hacksaw. So each of the people in the back of the pickup truck took 5 minutes of vigorously sawing off this lock. We finally broke in for our own supplies, had to load it in a pickup truck and bring it across because we were trying to get surgeries arranged that week. But again, this is the last trip. And this is a wonderful picture where here you have Ethiopian doctors using now telescopes rather than microscope, which is a lot more practical. And on the left, we furnished a video cart. On the right, they'd obtained a video cart from Carl Storz. On the right is also Danielle Marchioni from Verona, Italy, who is an internationally known endoscopic ear surgeon pioneer. And he and a couple of his colleagues came and had just a wonderful week in 2019, our last trip. So what have we accomplished? Well, from where we all started, where ENT and hearing loss didn't exist, there's now 3 residency programs with a 4th that's supposed to start. There's been about 45 graduates, and we work closely with 12 of them, specifically with ear problems, where they're coordinating education and the surgical training with multiple international teams. They've developed hearing audiology programs, particularly with the Ethiopian American group out of Chicago. We've donated $250,000 worth of supplies, and this is like real eBay dollar supplies. This is not like business write-off or not, but a microscope at $100,000. We're valuing the microscope at like $3,000 to $5,000. So a lot of stuff, a lot of ORs and clinics have been outfitted. Again, no one has left the country that we have trained. Everyone that has graduated has stayed in the country to further, this effort, and has increased awareness of the prominence of ear disease and the role of prevention in particular. What we did find is that as people were getting older and with infected ears, you really couldn't reverse some of the ear damage. So early intervention was critical. And again, so this is sort of, again, some people down here. This is Miriam Redleaf. Dr. Redleaf is a neuro-otologist out of Chicago. This is Glenn Isaacson, who's out of Philadelphia and Temple with Healing Children, who's been there for years. And again, just wonderful people, all of them sort of like my graduates, and I know them better than my own residency graduates here in America. And thankfully, we're able to kind of keep touch and continue to support them. And on the right are my kids, just 4 of the 9 of them. So getting back to it, wrap it up, health justice medical missions. Can we use this to access equitable, affordable, quality healthcare for all? I would say, well, do international medical missions advocate for change? Yes, if done in a thoughtful, coordinated, targeted fashion. And can they promote achieving equal access for affordable quality care within the communities? Again, yes, they can, by building, supporting competent, enthusiastic core of people. And again, this very last trip, other than logistics, I'm stepping back. And I guess that's what you really want to do, is feel like you've raising a family. You put something in place, and if it's durable, which unfortunately it's had to have been durable over the past 2 years, and we can maybe talk about what's going on with Ethiopia now. But that's what you want to achieve. So I think that we've been fairly successful in doing that. That's it. Any questions or comments? Roberta, I think maybe you're probably looking at some things in the chat.
Yep. I'll go ahead and read some of the questions. First, I wanted to thank you for such an amazing presentation. I thought it was very captivating all the way through, and it was really great, your personal experiences, and just great. But I will get started with the first question. Hey, Dr. Kelly, do you think there are any roles for medical students who cannot function independently to meaningfully engage in global health?
I think it's more difficult now than ever for medical students to be involved in international things, because the countries there and the host countries have really sort of clamped down in terms of their expectations. So initially in 2009, medical students certainly could have gone. You could have gone to the airport and gotten a tourist visa, and then just sort of come along with the team and participated. And you could still do that as a tourist. And we've had residents, we've brought 4 residents with us. But even then, and now, you have to get an official medical license, and you have to be a practicing or certified practitioner here, and you have to demonstrate your medical degree to them and multiple other things. So it can be difficult to get fully engaged, but certainly, I would encourage participation as much as possible to sort of like tag along. And again, you may not think it's that helpful, but it really is. I mean, when the residents sort of come along and sort of, there's sort of this camaraderie between residents that we've brought and the Ethiopian residents, and I'm sure even down to the medical student level. And then once we get into this, era now where we're looking at, doing studies on, again, still not completely done, on the incidence of ear disease within communities. I mean, that's a perfect type project for a medical student to be involved. You really don't need, per se, your medical degree to do that. It can certainly contribute to the overall need and understanding the incidence of ear disease and what the barriers are for, access that still, I'm sure, remain.
Go to the next question. This is fascinating work, Dr. Kelly. Could you speak a bit more about some of the most important things you have learned from the medical staff in Ethiopia via your work? It is clear what the medical staff in Ethiopia have learned from your program, but what you learned in turn from them or from doing ear work in Africa.
I've learned to, well, it's kind of weird. I think I've learned a lot, but I have to be honest that when I come back to America, I'm filled with a little bit of bitterness at all the waste and how we take things so for granted. So, learning humility and just hard work and persistence from them, and just the amazing barriers that they've had to overcome just to get into medical school, to sort of, just be more grateful for what we have. But again, it comes with that little edge, at least for me, and maybe that's a personality flaw. So, and again, it's never perfect in terms of even the ethical things. And the one time that I butted heads, I wouldn't say butted heads, but we had a little bit of a disagreement is, we're there on a medical team to train, and there was this, a newborn who had this massive tumor in their neck with inability to swallow, a CT scan that was done. And yet, they persisted in wanting to do a tracheotomy in this child. And having been working there, being kind of an old goat, I kind of knew it was pretty much hopeless. And yet, the fact that they nevertheless, were more compassionate than me, sort of thinking of how this impacted the family and everything else. So I probably came off looking a little bit unsympathetic, but I was certainly sympathetic. I was sort of more focused. So just the appreciation for everything that they have, and yet really the humility and humanity that they still possess is amazing.
The next question, going off the bat, for students pursuing a surgical subspecialty, there seems to be a huge emphasis on research experiences and standardized test scores. How do you see medical missions or other volunteer experiences fitting into this equation now? And is there potential room for change in the coming years?
Well, there certainly, unfortunately, is this focus on scores. And I think even when we're looking at residency programs, there's this initial barrier where you have to have a certain level of scoring to sort of make it past the first cut. But having said that, I think beyond that, at least certainly in our program, and I think a lot of the other programs, at least with ear, nose, and throat, I can't speak to other specialties, there is sort of this focus much more on, what is this person made of in terms of what experiences they had, what are they bringing to the table in terms of this more healthy approach. So I do think it's a factor. I think it is sort of noted. I don't know if in the short term we're going to get past, unfortunately, that initial cut of scores. But I'm hopeful that that'll be lowered and we can take more of a look and more emphasis on work and interest that people have done globally, or certainly even in the local community. I think it's important. I think it makes her a better human being and a better physician.
Right, so I had a couple questions myself. The first was, do you have any organizations that you'd recommend us joining that do good quality global health work, in your opinion?
Again, I've sort of been pigeonholed into this, effort in Ethiopia, and so I do know all the people, and if and when things are ramped up again, I'd be more than happy to put people in touch to see if there's a way that you can kind of, given that know some background, the backstory, beyond that. I think it sort of depends on the specialty. I don't know of any particular large group that I would necessarily be in a position to endorse right now, though.
Another question I had was, how did you deal with the language barrier? I feel like that's a concern for me when going abroad.
Again, thankfully, they teach math and science beyond fourth grade in English, and medical school people, medical training is all in English. So with the physicians, it was easy. And given that we were inviting other residents and other physicians to come on these trips when we were in attendance, there's no issue at all, because inevitably, that would be translated to the nurses and staff and everything else. So you always had to have someone by your side, but it really is not a huge issue. And then another thing is, every time I'd be in that long flight over there, I'd take out my little book where I tried to write down 2 or 3 phrases from the year before, or from the 6 months before. And so if you throw in an occasional Amharic word or phrase, you can ask for a cup of coffee in the morning, or say good morning or thank you. It goes a long way. They actually, it's quite an icebreaker. So, shame on us for not trying to learn their language more. But in our defense, Amharic is their official language, but only 2 out of 3 people actually speak it. It was even less than that back then, in 2010. But certainly, if you go to these local Ethiopian restaurants, go ahead and engage with a little bit of conversation and learn a couple of phrases.
We have another question from a student. Have you thought about writing up a sort of curriculum or formula to teach other medical trip programs to make their programs more sustainable?
I've thought about that recently, only because we've had this pause because of COVID, and now, unfortunately, because of this unwinding of this ethnic feudalism, which is what was sort of put in place 20 years ago by Meles Zenawi, who took power in 1991, sort of having each state, each zone having their own ethnicity defined, and yet allowing, therefore, there to be discrimination between one versus another ethnic party. So as that unwinds right now in this pseudo civil war that's going on with State Department level 5, you can't travel there. This pause has sort of given us a reason to sort of sit back and take a look at this, and perhaps the parties that are involved between Glenn and Miriam and Jerry and all these other people that have traveled there numerous times, to actually perhaps sit down and have better documentation of what we've accomplished and what we've done, how we've gone about it. And maybe that could serve as a model to help other people. So this picture, I got to say something about this picture. This picture was our last trip, and it was in the Simeon Mountains, which is kind of in the northwest area. And those are the 2 or 3 people that, at this elevation of 12,000 feet, and my being about 60 years old, you get down there, and the thing is, we had to walk back uphill from that point. So I took the picture of them down there, and it's just spectacular scenery. And then, of course, we were dumb and had a challenge. So from that point, we raced up about 800 to 1,000 feet, only to see who would have the highest heart rate and who would have the lowest oxygen saturation, because we happen to have these little finger ones. So I set the record in the over 50 age group. I got my oxygen saturation down to 80 and a heart rate of 160. One of the younger folks got his saturation down to 78%. And then as we're sitting there having a beer, we're thinking that's a pretty stupid thing we just did, because we're in the middle of absolutely nowhere, and God forbid someone had some chest pain, that we would have been buried somewhere in that valley. But again, certainly encourage people to at some point in your lives participate in a medical mission. Ideally, younger is better than older, and get out there and do some good.
Dr. Kelly, one more quick question. Are you aware of any residency programs that integrate global health work into the surgical subspecialty residency? I know a lot of programs give time for research blocks and things like that, but I was wondering specifically about global health work.
I don't think on a formal basis, but again, our American Academy and the, I think 108 ENT programs, you'll see that, they're encouraging residents to go on these medical trips. They do have grants that are available. I'm not aware that whether one program or programs in particular, build that into their criteria. I think a lot of the times it's sort of taken on their vacation time. And you certainly do see some programs where more students are likely to go. And I think that depends on, the staff. If you have staff at a particular hospital where they're participating in humanitarian efforts committee, or they've done medical trips, certainly you can have residents within their programs that would be more likely to go. But I'm not sure that it's really built in at this point to any programs for residency.
Well, thank you so much for taking the time to prepare this presentation and be with us here today. This was a new topic for the Health Justice Conference, so we were really excited to get this rolling and to have this discussion. So thank you so much. If there's no more questions, I think Roberta can send the links to the following session in the chat for everyone. And yeah, if there's any remaining questions, please feel free. Okay, everyone, I have 10 o'clock here, so we can go ahead and get started. Thank you for joining us in this session. I'll start with some logistics and then introduce Dr. Sunny Aslam. Live captioning is available if you would like. And to turn this on for yourself, please hit the 3 dots on the bottom of the Zoom screen and click Show Subtitle. For this session, please send questions in the chat, and then these questions will be read aloud and answered during the final 15 minutes of the session. Towards the end of the session, Alexis will be sending links for breakout session, or for the main room again. And these links are the same as provided in the schedule that was provided to you via email. So Dr. Sunny Aslam completed his residency training in general psychiatry at Upstate in 2011. He specializes in psychiatry and neurology, addiction medicine, and pain management. Sunny is a member of the American Association of Community Psychiatrists, the American Public Health Association, and the Onondaga County Medical Society, where he serves as the SUNY Upstate representative to the executive committee. We are very grateful for Sunny for being here today, and go ahead.
Great, thanks so much for having me. Honored to be here. This is a cool conference. As many you know, it's been going on for a number of years, and a lot of work goes into it. And it's an honor to be a part of this. So I'm very informal. So I'm going to try to keep my remarks to really a minimum, and then hopefully we can have a discussion about whatever you guys want to talk about. My work encompasses a lot of things, and so I'm going to introduce like maybe 5-10 different concepts, briefly, and then hopefully 1 or 2 of those will grab you guys, and we can have a vigorous discussion and debate during this hour together. So I love to get everybody involved. And so if you have a smartphone and you want to respond to the question here about recovery, you can do that by texting Sunny Aslam 319 to the number 22333. And then the questions will pop up on your phone. And you can put in A, B, C, D, or E. We'll do a few of these questions now and during the presentation, but it's just a fun chance to try to do some teaching and see where everyone's at too. So recovery is often associated with the substance use disorders, but also in mental health. Recovery is a very important concept, and it looks like, as most of you, everybody who was answered got this correct, right? Freud said work and love is what life's all about. Of course, symptomatic recovery is very important, but functional recovery is as or maybe more important than symptomatic recovery, and we can talk about the differences if you guys would like. And in the work I do, particularly addiction, but also mental health as well, we want to respect patients' autonomy. Just because my goal for them is XYZ does not mean that their goal is XYZ. And this can become very difficult when patients don't do what we want them to do or think that they should do. So we can talk about that. And then the dignity of risk is a very important concept in mental health, which we can talk about as well if you guys want to. And you guys, everybody who participated got it right, all of the above. right. Let's see if I can get to the next slide here. It's not moving for me. What am I doing wrong? I wonder if my screen is frozen because this is not moving ahead for me.
If you look at the lower left, it looks like there's an arrow. Maybe that will.
There you go.
Got it.
Okay, great. I'll use that. All right, so next is, many of you may know or may not know about adverse childhood events. So we can talk about this. These are just questions to see where folks are at. So do your best if you'd like to answer them. But what percent of the US population has at least one adverse childhood event? Do you think it's everybody? Do you think it's 61, 51, 26, or 9%? So adverse childhood events can include abuse, neglect, witnessing domestic violence, having a parent with a psychiatric illness, etc. Those are considered adverse childhood events. There are 10 main ones that are made up of the adverse childhood event scale. And then so the scale's rated 0 to 10. What do you guys think? We've got 102 participants in here. We've got 19-20 answers. So I'm going to give you guys a few more seconds. Again, all you got to do is get your smartphone and text Sunny Aslam 319 to the number 22333, and then pick one of those letters. It'll tell you you've been entered into the survey, and you just pick one of the letters corresponding with the answer you think is correct. Do you think everybody has an adverse childhood event? Do you think 9% do, or somewhere in between? We're at almost 30 responses, so I'm going to move ahead here, but you can keep answering. So far, most people think it's 61%. A large majority of people think it's 61%. A small group thinks it's everybody. Nobody thinks 9% is a correct answer. So interesting. All right, so let me lock it in. And you guys were right in this case. 71% of you were right. 61% of the population, so nearly 2 out of every 3 people in our country have some type of adverse childhood event, whether it's abuse, neglect, substance use in the family, a parent in jail. We're going to talk a little bit today about how our criminal injustice system is deeply tied to the work of mental health and substance use disorders. But yes, that is correct. According to the CDC, 61% of our population has an adverse childhood event. Okay, what about schizophrenia? So schizophrenia is a chronic mental illness that involves people who have symptoms like hallucinations, delusions, negative symptoms like lack of motivation, affect, etc., and cognitive symptoms that involve disruptions in thinking, memory, what's called executive function, which is planning and follow through. So what are recovery rates for schizophrenia? Do you think it's 1%, 2%, 5%, half to 2/3, or are none of these accurate? Do you think there's some other number? Is it 100%? Is it 0%? Great, we're getting a ton of answers here. This is what I love to see. People participating and with very different opinions about what the correct answer is. All right. So Nadia, I can't see the number of responses on this one, which is okay, but I just want to make sure I'm giving people a chance to respond. Let's do 5 to 10 more seconds. But again, you can text Sunny Aslam 319 to that number 22333, and then pick one answer, A, B, C, D, or E, based on what you think. Who recovers from, what are recovery rates for schizophrenia? All right, last call. Lock it in. Oops, that's not what I meant to do. Okay, so in this case, most everybody was wrong. Published recovery rates for schizophrenia range from 1/2 to 2/3. This is not well known. We in medical training, we're often taught, this group of people is pretty hopeless. You just kind of medicate them and take care of them for the rest of their lives. Well, it's not true. Although schizophrenia is a devastating illness, and when people are involved at the hospital level, where they're admitted to the psychiatric unit, for example, with severe symptoms, or we see a lot of people, homeless folks on the streets, or when we interact with people with schizophrenia, it might seem like this is a hopeless disease that never gets better. That's just not true. And we can talk about one of the largest studies of people with schizophrenia. They were followed for 34 years, called the Vermont Longitudinal Study, that shows that schizophrenia people have significant rates of recovery with appropriate treatment. So Part of my job is I work in what's called assertive community treatment. And I'm just wondering, does anybody know what the heck assertive community treatment is? Is it A, medications for schizophrenia, including long-acting injectable medications and clozapine? Does it involve a multidisciplinary team, including peers, that goes to patients in the community to provide treatment, vocational and housing assistance, and a transitional team that helps patients with their recovery goals? What do you guys think assertive community treatment is? Or maybe some of you know or have even worked in it. This is what I do 2.5 days a week. All right, so it looks like most of you got it. A large majority of you said it's all of us, and that's right. Assertive community treatment is a group of us, a team of 10 of us, interdisciplinary team here in the county, Onondaga County, who go to our patients, and we provide medications. We have peer staff. We help people with housing and getting work, and we're transitional. So the idea is, again, that we're not going to be taking care of these folks or working with them for the rest of their lives. We are one step in their recovery. And often this is one of the reasons why I want to spend some time today talking about incarceration, criminal justice system, parole, probation, because so many of our folks are discharged or go in and out of institutions like prisons, jails, parole, and probation. So yes, this is what assertive community treatment is, and we will have a chance to talk in more depth for those of you who are interested. So why do we do assertive community treatment? What are the benefits of it? Does it A, reduce homelessness, B, reduce hospitalizations, C, emphasize patient strengths in adapting to community life versus focusing on disease, D, result in greater satisfaction with treatment among patients and their family, or all the above? I don't like trick questions. The whole point of this is teaching. So you can see this is one way I can introduce a number of topics through a single question. So hopefully this will help people who are interested in learning, but absolutely right. Assertive community treatment has been shown through studies, and it's one of the reasons why it's one of the main community-based treatments for people with chronic schizophrenia, essentially. Not everybody we work with has schizophrenia, but almost everybody does have schizophrenia, and this is the evidence-based way to reach folks who don't participate in traditional treatment. Most people with schizophrenia will come to a clinic, and then they'll get their medications, their therapy, whatever other referrals they need for work, housing, etc. But there's a small group of folks who do not come to clinics. They can't, won't, or are unable to because of whatever limitations or reasons, lack of insight, poor judgment, poverty, cognition, trauma, distrust. So we go to them and provide treatment. That's assertive community treatment. Okay, so some of you may recognize this is Dr. Dave Lehman, who is the founder of House Calls for the Homeless at Upstate. And so he's my buddy, and we are partners in this work. He handles internal medicine and so much. And then I help with the mental health and substance use disorders aspect of working with a lot of folks who live in terrible poverty. And of course, this is basic public health we provide for folks, along with a lot of psychosocial services. People need a lot of poverty services, and they, basic public health, food, clothing, shelter, helping people quit using cigarettes, basic physical, mental, emotional health, and then substance use disorders. These folks are so traumatized, they need, we need to use different approaches to working with people who don't have trust in the system that they feel has left them behind, neglected them, or never helped them. And so that's why Dave and I go to folks and try to provide with our teams who do a tremendous amount of work, try to provide for people's needs. And often it's a pair of socks or a sandwich. It's not necessarily you showing up and being a medical doctor. It's you showing up and being a human being and helping people with basic needs. Someone who's homeless. 2 weeks ago, I went and saw someone who's living in an abandoned house where the floorboards weren't safely in place. And so and that night was one of those nights where it was going to be very, very cold. And thank God we teamed up with the rescue mission outreach team who came over, and he agreed. I didn't think he was going to agree to go to a shelter, but he did. He has 2 below the knee amputations. And it was noted once he got to the shelter that they were both Black. So then we became extremely worried about necrosis and possible death. So I'm just kind of highlighting the level of complication with our patients, and that they sometimes urgently appear that they're on the edge of death. And of course, some of them do die, which is very difficult. But it's a reality for this kind of work. So that's Dave. I'm Sunny, and I'm a community and addiction psychiatrist. And let's dive in. So my objectives today were just to discuss how to work with vulnerable populations. It's fun, exciting, it's sad and devastating. It's frustrating and exhilarating. It's just, it involves highs and lows and a basic service to the community. I think it's, this is what my parents instilled in me. So I'm very privileged and very lucky to have what I have. And we were always involved in the community doing a lot of different things. And then this translated into my medical work, as it did for my father as well. So we'll talk about goals of community psychiatry. We talked a little bit about autonomy. We've talked about recovery already. Spirituality, how in addiction, if you don't have a spiritual basis, the chance of maintaining sobriety is almost zero. Now, notice I didn't say religious, I said spiritual. They're different, and we can talk about those things, but that the basis of this work is outreach and engagement. So we're going out in the community and working with folks who just are so marginalized and vulnerable, and unable to participate in regular treatment. And we'll talk about, it's like I mentioned, it involves so many emotions to do this work, and I'm very grateful to be able to do it, but we also want to train the next generation of people to do this work. So we're always trying to find medical students, residents, other trainees, PA students, and nurse practitioner students, so physician assistant students or PAs, to come along and do this work, because we want people to get excited about doing it. Because there's always a shortage of people doing this work. There's always a shortage of funding. We need activists involved in this work who aren't afraid to make some noise and ask for more funding for this work. It seems it's chronically underfunded. We're always fighting for grants and for longer term funding to be able to do this work. And so I wanted to talk about how, the goals of this work, and then identify the benefits to trainees. And the bottom line is, a lot of trainees get very excited about doing this work. They love being out in the community, the creativity that's involved, the chance to work with vulnerable and marginalized populations. So there are a lot of benefits to this, but it's complicated. That's often administrators or people who are responsible for others are worried about safety, and we can talk about those things. There are risks involved. It's not, nothing is without risk, right? So we can talk about the levels of risk that come with this work. But in general, I think this is a very worthwhile, and it appears to be very popular with a lot of our trainees who want to get involved in different programming. And you'll see later in the presentation how doing this work, if you're out in the community already doing mental health and substance use disorder work, then we are poised during crises to add or pivot to different types of necessary work. And I'll show you some programs that we've designed and been involved in during the pandemic that we were the logical choice to be able to do this work, because we're already out in the community and already have built relationships with a number of groups in the community. Okay, and of course, so we're at a health justice conference, and we cannot get away from the intersection of poverty, racial, and the criminal justice system. These areas, my patients live in terrible poverty. They deal with racism, and they deal with cycling in and out of institutions, including incarceration, parole, and probation, and it's very difficult to see. So we can talk in depth about that as well. So we talked a little bit about adverse childhood events. 61% of the population has at least one of these. So you can see emotional, physical, and sexual abuse, household challenges like domestic violence and substance use disorders in the home, mental illness, separation, divorce. Those are devastating to families and to children, or an incarcerated parent as well. There can be physical and emotional neglect. So I just want to point out, if we go to the bottom right, you see the pyramid. So what's the basic understanding of how adverse childhood experiences affect the 61% or more of the population that has one? So if you think about, mom's drinking, dad's in jail, you're physically or emotionally abused, that disrupts your brain development. How could your brain develop appropriately when, you know, there's literally physical abuse going on in front of you, or your parents are unavailable, etc. So your wiring, your biochemistry changes over time. And this, of course, affects your social, emotional, and cognitive abilities. You know, you go into school, you can't concentrate. Everybody thinks you have ADHD, but you're just worried about what's going to happen when you get home and your uncle sexually abuses you, or your father beats you, or, you know, mom's going to be inhaling cocaine, or parents are going to be gone. You're going to be on your own. Where am I going to find food? So you can't think straight. So you can't have relationships. How do you connect with people in class or your teacher in appropriate ways when you're, you know, emotionally and your brain is just trying to survive. You're in survival mode. So with all this, of course, comes overwhelming feelings of despair, hopelessness, anger, etc. And what can make that go away? Well, I'm going to inhale 30 cigarettes a day. You know, I'm going to start drinking at a young age. I'm going to, you know, get involved in different types of compulsive activities like overeating, for example. So food addiction can start. And of course, these behaviors lead to disease, disability, and social problems. You can't have healthy relationships with people because you just don't trust anybody. And why would you when you're, you know, being abused, neglected, etc., by the people who are supposed to love you? So if you're eating all the time, you're going to develop a number of, you know, metabolic diseases, obesity, etc. And then, you know, if you're inhaling all these cigarettes, using drugs, not taking care of yourself, you just are putting yourself at extremely high risk for early death. You know, and you can see a number of other statistics here, but adverse child events are the single greatest unaddressed public health threat, according to Dr. Robert Block, president of the American Academy of Pediatrics. So my work, you know, where did this come from for me? People often ask, so I just share with people. My dad, you know, came from India in the 60s. He had nothing. He wanted to be a surgeon. He worked tirelessly for years to become a surgeon and build a surgical practice. And, you know, he saw a lot of poverty where he grew up and living in Baltimore, New York City, and Tennessee. He, in fact, an interesting note for my family history, my father worked at the hospital that Martin Luther King Jr. was organizing at the day before he was killed. So my dad was actually a Memphis general, and Martin Luther King later in his life, you know, he was fighting for civil rights, racial justice, but he started what's called the Poor People's Campaign, where he extended even beyond, he spoke out against the Vietnam War, and he was fighting for, you know, against the poverty. And, you know, he was called communist and all these kinds of things back then. My father actually worked at the hospital he was organizing the janitorial staff at for, you know, for a working wage. You know, I remember my dad telling me, you know, many of the staff at the hospitals at those times couldn't afford to eat. And he said, you know, he worked at the black hospital there. And he said the staff used to feed people for free there. They would just give them food. And he, you know, I just, you know, the stories my dad will share when he will about some of these things are very moving. So anyway, he and mom started us working and doing a lot of community service at a young age. So I worked in the soup kitchen, you know, up through my years as a teenager, and even into college. I'd come back home with my girlfriend. I remember coming back home and working in the soup kitchen. So I had this, you know, I had this service in my blood, in my family, which was wonderful because we would all go to the soup kitchen and work there together. And I just kept this with me. And I remember when I arrived in town 14 and a half years ago, one of the first things I did, my residency director said, hey, there's a medical student run free clinic in the basement of the Civic Center. Who wants to go work? And I went and worked there. And it was, you know, it's just a wonderful experience. I got to meet some really cool people there. People who work with refugees and you know, really got introduced, and just kind of lucky over the years to have really a set of really cool mentors who were interested in this work. And I think that's the way this works. Sometimes you know, you're just drawn to people who you have a lot of similarities with, and you're at this health justice conference probably for a reason, you know, because you're interested in these issues, and you'll just tend to find mentors and people who will help you along the way. So then, you know, I went through residency and then did a year of fellowship, and then I decided to go work at a public clinic locally. clinics serving the sickest of the poor, poorest of the sick. And I was bored at first. I was in the office. It was very slow. It was a very controlled system. Because of administrative and other bureaucratic reasons, they didn't want, my bias was that they didn't want too many patients in the clinic. So they limited the front door, and that drove me crazy because I was sitting in my office wondering why I didn't have wall-to-wall patients. And so I told my boss, who was, he's like, great, I'm going to give you more work to do. And he sent me out in the community to start seeing people out in the community. And I had done some work during medical school and residency. I'd worked on an ACT team actually in both medical school and residency. So I had some idea about this work. But that really got me started down a path of designing programs and doing a lot of creative work. So I've been lucky. I had willingness, I had mentors, and I started to get some experience. And what that involved a lot of was building relationships with community organizations. So I could do the doctor part. I could assess somebody and technically decide what are their symptoms, what's a diagnosis, prescribe a medication. But it was a necessary but far from sufficient part of helping these people. They needed much, much more. So we needed help from housing providers. A lot of them wanted to work. So we needed help from vocational staff or referrals to agencies. And I wanted it to be a training program, to train people to do this work so that one day when I'm gone, someone else will be well-trained and have experience and get to see that this is some of the most rewarding and exciting work that you can do, in my opinion. And it became clear when you're working with people in terrible poverty, the urgent needs and the limitations on what's available out there. And that we often have to speak up and fight for our patients. So my first job, I worked for 6.5 years at the public clinic, and we developed our own program, basically our own outreach team. We called it Tier 1. We were going to we had 3 tiers in our clinic. We had Tier 3, which is people who came in once every 3 months for their medication refills. Tier 2 were people who were more actively involved in clinical treatment, maybe not as stable as Tier 3, but they wanted to come in for regular therapy, meds, and other programming. And then Tier 1 were the folks who wouldn't consistently come in and were quite ill. And so we had an internal referral program that people could be referred to Tier 1. And of course, it filled up almost immediately. We had some social workers, a nurse, and 2 of us psychiatrists and a psych nurse practitioner used to go out in the community and do this work. So we would go out and then we were partnering with other agencies. So John Tomino from In My Father's Kitchen is a good friend of mine, and he runs a private homeless outreach program that's become even much more now. Now it's a jobs program. It's a human sex trafficking program, working with people who are victims of sex trafficking, et cetera. And we were out on streets, bridges, encampments, and we're spending a lot of time at shelters and just working with, it feels like every poverty organization locally. We're lucky to have a good relationship with them. And so, over the years, it would just become clear to me we're doing 10 things and there's 30 more we need to do to help people. Why can't we do them? We were able at my clinic, we developed a walk-in screening program. We had daily walk-in prescriber hours. So we were really able to do some cutting edge things. We had open access scheduling. And these things were big changes that took a long time and really were very challenging in a lot of ways, but we were always thinking about different ways to do more. So I had mentioned one of the ways we do more is that we, as an outreach team, we are very well positioned to quickly move to other aspects of providing care for people. So the pandemic hit, it was clear to see that vaccinations, the homeless and vulnerable population were not necessarily getting vaccinated at the same rate as everybody else was. So we designed our own program. And so Alana, Roberta, and others, medical students, I really wanted the medical students to lead this program. I think it's really, it's really important that we want to build medical student leadership. I can do this and it's fun for me to do it and put my name on it, but it's even more fun to see students that you're working with to have the chance to lead the way. And so I let the students really take this and run with it. And it was fun. We vaccinated nearly 200 people, I think, at our last count. And so we were doing this for a few months, and then this was when cases went to about 0. And we were in the single digits on days we were doing this. And so we stopped the program. And then recently we restarted it. And last Tuesday, we ran out of vaccine by noon. We had vaccinated about 40 people by noon. We did 20 the week before on Thursday during our first day. And so it's clear that the need is there again, and we're back, we're out there doing it. We already are fully booked Tuesday at like 4 or 5 sites. We're going to shelters, we're going to group homes, and it's clear there's a desperate need for people to get their vaccinations. And we're, like I said, we're well positioned as an outreach team to just add giving injections. Interesting fact, I had never given an injection before last year, and now I've given hundreds, probably 1,000 of them, and overseen this team and whatever. But it's, as a psychiatrist now, we've deferred so much as physicians to nurses. But this was a great chance, a great experience for me. Now I know what hundreds, maybe 1,000 shoulders look like in the Syracuse area, and I've put vaccines in them, and it's a great feeling to have been involved and to have our students leading the way. So for those who are interested in the academic side of this and getting more involved, there's academic street medicine, and I want to put this reference in. This presentation, by the way, is available to anybody who wants it. I'm happy to send Nadia a copy, and hopefully it can be distributed to anybody who would like it. I always share all my slides. So the Academic Street Program has been designed over the past few years to promote academic street medicine, to get trainees involved, to get them excited about this work. And so it's been written about over the past 4 or 5 years. We've seen more and more in the media about programs that treat the homeless, medical programs that treat the homeless. This was a great article in the Washington Post from about 4 or 5 years ago. There are many financial benefits. I don't really want to focus on that today, but this is often how you have to make your argument to administration, is they want to know, is this going to cost money or save money? And this is a developing area. So I think, it's developing, but I do want to put slides in there for those of you who want to have this information, if you want to make your argument for a program at your, wherever you are. And so here's more data. Here's Dave taking care of patients in the back of the van. And so one of the ways, there are a number of mechanisms for doing this kind of work, and one of them is called Healthcare for the Homeless. And so this is a national program, and it's run out of federally qualified health centers. And so our example in Syracuse is our Safety Net Health Center, FQHC, federally qualified health center, is called Syracuse Community Health Center. And so there are 200 plus of these programs in all 50 states. Rochester and Buffalo have them. Believe it or not, we don't have one in Syracuse yet, but this is in the works, and I'm hopeful that hopefully this year, if not next, this will happen. And how federally qualified health centers work is, at the most basic level, they receive basically increased funding for taking care of the most vulnerable folks. So all this comes down to money. It's just the way the world works. Whether I want it to be or not, it's the way things work. And so the federally qualified health centers get a higher rate of reimbursement for taking care of the sickest and poorest people. And so that's one of the advantages of working at the community health center. And then also, since federally qualified health centers are the only groups that have access to this money for healthcare for the homeless. And so again, that's the advantage of being a federally qualified health center like Syracuse Community Health Center. So I want to really wrap things up in the next few slides. So I'm going to go quickly, and then we can talk about in depth more what you guys want to talk about. So there are immense challenges, funding being at the top of the list, bureaucracy and administration being on the list as well. Everybody's wall to wall with using, with their budgets are stretched and staff are stretched. So it's like, how do you add anything into your day? Levels of burnout are already high. We've been in this pandemic for almost 2 years now, and it's just really, really difficult for everybody. We can talk more in depth about challenges that people want. But the 2.5 days a week, I do the assertive community treatment. We've covered most of this. A lot of this is technical language that is probably uninteresting to many of you, but patients are referred to us through certain programs through our county, actually. So people have to fill out paperwork and and do a referral to the county, and really only hospitals, inpatient hospitals, psych units, and a few other people can do it because we have a limited census of 68. But parole, probation are often involved. Our patients cycle in and out of institutions, so hospitals, homelessness, incarceration, et cetera. And we have a census of only 68. And I've certainly made my argument for more ACT teams here locally in the poorest city by ethnic segregation. We certainly need it. So our team's multidisciplinary. So we have peer staff, a psychiatrist, a psych nurse practitioner, nursing, social work. We focus on substance use disorders, housing, and we connect with families as well. So that's one of the keys to success for people who are so ill is connecting with family if they have any that want to participate. And we try to see people at least 6 times a month. That means our team of 10, out of those 10, try to see, the prescribers try to see people at least once a month, sometimes more if we're lucky. And there are 2 of us, so I don't even see every patient necessarily every month myself. So I just want to ask, what is a peer in mental health and substance use treatment? Is it a friend you work with, someone to convince patients to take their medications, a person with lived experience in the field who's in recovery, an advocate for patients in the hospital that can be requested, or is it none of those? Is it something else? Ten more seconds. We got a competition going between C and D. So about a little more than 2/3 think it's C, and a little less than a third think it's D. So in this case, a peer actually is someone who's a person with lived experience in the field who's in recovery, either with a mental illness or substance use disorder or both. But that is what a peer is. So one example of a peer group would be 12-step groups, like Alcoholics Anonymous would be considered the flagship of peer-run program. 12-step groups: Alcoholics Anonymous, Sex Addicts Anonymous, Narcotics Anonymous, Gamblers Anonymous, Overeaters Anonymous. There's a 12-step group these days for everyone. If you have someone with alcoholism, you can go to Al-Anon. If you come from a dysfunctional family, you can go to the Adult Child Dysfunctional Family Group. There's tons of groups. I go to the Adult Child Dysfunctional Family Group, which has been a wonderful experience for me. Let's see. Okay, so we talked a little bit about making the assessment to our team, but that's always an option to do through the county for certain groups if people are going to the psychiatric emergency room or hospital repeatedly. And then we work with people closely. This is intensive work because often folks don't want to work with us. We're going to them. It's hard to find them. We may not see them regularly, or they're very ill, and often interacting with criminal justice system, et cetera. Course of treatment involves much more than just medications, substance use treatment, family connection, housing, working with folks around their housing and learning to live independently. We have a peer on our team, and she's terrific. Her name's Wendy, and she is a very impressive woman who's been in recovery forever and really provides us an extra tool of how to connect with people who don't want to listen to the pill pusher. You know, they see me coming and they cringe because I'm gonna, I have to ask them about their medications. Are they taking them? Are they having side effects, et cetera? And a lot of them just hate medications. It feels like another form of control, or they think I'm poisoning them, et cetera. So a peer has a totally different role and can connect with patients in a different way. And then basic self-care, education, and work are things we discuss with people. And then we eventually, if people transition from the team, and we try to let them know from the beginning, we talk to them, what would need to happen in order for you to transition to a clinic? And this can take some time, as you can imagine. And eventually people will be discharged to a clinic level of care or their primary care or wherever they want to be. And we still follow up with them for some time to make sure they're doing okay in transitioning. So we have a number of goals, and we've talked about those. It's really what the client's goals are, or what we try to help them with. And for staff, it's to try to continue professional development and try to make work that's very difficult and often frustrating fun. To let go of our sense of responsibility and control for people that have to make their own decisions, which can be very difficult. We're the smart people, we're the doctors, we know the answers, we think everybody else should too, and just do what we say. And of course, that's rarely what happens in our field. So we've tried, one of the hot topics is integration with primary care. So I'm not going to spend any time on this today, but I put slides in here for those of you who want to look through some of the data. We need to, in mental health and substance use field, integrate with primary care as much as we can. So, you know, if you become a psychiatrist, the first thing you want to do is find somebody in internal or family medicine and make them your best friend and trade phone numbers so that you can, you know, so I can just call my buddy Igor and just say, Igor, I don't know what to do with this medical issue with this person. What do you suggest? Or call Dave Lehman or whoever it is so that I can get the help I need to get my patients the primary care they need. I'm going to skip some of these slides. Again, anyone's welcome to this presentation, but I really want to wrap up the next couple minutes so we can talk. So there's a book out by Michelle Alexander called The New Jim Crow, and it just blew my mind away of things that I think I've partially probably heard about and understood, but just to become so frustrated about that. If you want to talk about health justice, you have to talk about what's going on in our criminal and justice system. And we imprison more people in our adult population than any country in the world. So in the media, you hear about horrible, repressive countries like Iran, Russia, China. We imprison far more people than those countries do. So I just question people to think about, it's always easy to point the finger at somebody else and talk about how horrible what they're doing is, but we always need to be focusing on things that we have some control and say over. I don't have a whole lot to say about what happens in China, but boy, I can participate in the discussion about what's going on in my own community. And by 2005, you know, 40% of the incarcerated population was African-American men. I mean, they make up 13% of the population with similar crime rates between white and Black people. So it's like, what is going on here? And that Alexander argues that mass incarceration and deportation are devastating forms of control. They're often based on nonviolent activity, minor crimes based around poverty. So what's really going on here? We don't have time to talk about all these things, but this is like what we see all the time. One of my patients said one day he was hungry and he stole a banana with a butter knife. And 10 years later, he's still on basically on a form of parole. And I'm like, you know, this is using up a huge amount of state resources. He feels totally controlled because he was hungry one day, you know, and it's just seems bizarre. So if we look around the world, so you can see the darker the shade, the more people are incarcerated per 100,000. The US is far and away the most people who are incarcerated. So we have about 2.3 million people incarcerated in this country. And then we have 4.5 million on parole or probation. Twice as many who are incarcerated are on parole or probation under state control or supervision. And you can look at other countries. Again, we like to point at Cuba. Cuba is the most horrible country in the world, according to, you know, many people here in the US. And we don't even imprison we imprison far more than they do in Cuba or El Salvador, Turkmenistan, other places. So, I mean, Russia, Iran, China aren't even, you know, really in our neighborhood. So again, we talked about like what's going on with white men versus Black men in prison. Again, rates of crime are very similar. Rates of drug use are very similar. But you can see astronomical numbers of Black men in prison. So Alexander argues, you know, we moved from slavery to Jim Crow to mass incarceration and deportation now. So this is I mean, again, I can't survey, you know, 400 years of history in our country, but, you know, read Alexander, look at the statistics yourself, and then decide, is this really where we want to be and what's acceptable to us? And we talk about bail reform. You hear how horrible bail reform is, that people, you know, poor people are kept in prison, you see here, because they can't afford to get out on bail. You know, if you're wealthy, you can afford it. You can afford a lawyer, you can afford bail, you can get out. Whereas we keep a huge number of people who basically live in poverty in prison for misdemeanors and other, you know, nonviolent crimes. And this has made up all the difference in net jail growth in the past 20 years. So here are the numbers I mentioned before. You know, we think of people who are incarcerated, either prison. Prison typically is defined as 1 year or more. Jail is 1 year, less than 1 year. But look at the number of people on parole and probation. It's a huge number of people. So I just wanted to bring that up to your attention so you can think about it and read more about it and decide, you know, how do we have this discussion about what's happening in our in our criminal injustice system. I keep calling it criminal injustice because it just seems obscene to me, the explosion in prisons in our country and what's happened, but it's a whole nother discussion. In summary, the work I do is fun and devastating, as I mentioned. It's it's not for everybody. If you're going to obsess and worry about every detail of what's happening with every person and think you can control what's going on with my patients, you will be miserable. But if you can let go of some responsibility and give patients options and develop a long-term relationship, then I think people find the work really exciting. It's never boring, I'll tell you that much. We should expect people to recover. Not everybody will, but if we let people know we expect them to recover, then the way I think of it is, in the early part of my training, I learned more about schizophrenia being a hopeless disease and thinking people couldn't recover. Then as I had more experience and read more, I saw that if the expectation is recovery, many people will recover. And that's that Vermont longitudinal study that I think is the best example of that. So if you want to read more about that, I think that's a great place to start. And this type of work is about collaboration, mentorship, and relationships. So I've had great mentors who've helped me, since I was a child, develop this interest and fortitude to do this work. And then I've just been lucky to have opportunities. And then it's about building relationships and taking care of myself too. I haven't always had the best self-care. I've had to learn and change and adapt of how to take care of myself better, because it's easy to focus all my time on working. And that wasn't an effective approach to doing this work. We live in a really fragmented healthcare system and a criminal system that just seems obscenely out of control right now, leaving us with a lot of work to do on behalf of our patients and public health. Because to me, this is the basis of, is taking care of the most vulnerable. It's the basis of how we treat everybody. If we don't take care of the most vulnerable, we're not doing our job as physicians. So great, that's it. Let's we've got some questions. Let's see if I can stop sharing my screen here, and then we can look at each other. Thanks so much for listening to me go on and on for 45 minutes. Wow. What should we talk about now?
Lots of people have questions for you. So the first question, Amanda, she says, thank you. And she asked, having to keep money budget in mind in order to request funding and programs, do administrators see a decrease in hospital admissions as monetary benefit, or does that mean less money in the hospital's pocket? And do Medicaid patients ultimately cost the hospital money?
Yeah, so it's a complicated question, but it's very relevant in that, yeah, the fee-for-service system that we're in, often it can work for us, it can work against us. There's no perfect system. There are a number of different ways of financing healthcare, and with this kind of work, there's so many different levels of complication here. I think about the treatments my patients sometimes get when they go to the emergency department. I think of, the one administrator who did say to me one time, don't cut these people off from coming to the emergency department. That's where the hospital makes their money. And so it is a very complicated issue with a lot of level of nuances. And our job is, or I see my job is, to advocate for my patients. And so, my patients going to one hospital, and it's not going well. I talk to the staff there to see what we can change. Continues to not go well, then I have them go to another hospital. And I call my people at that hospital and try to advocate for them there. And I try not to worry too much about the money. I need money to run my programs. I look for grants. We look for administrators who will support us. But I try to not focus on the money as much as I can, but realize it's a reality that some of these things are very complicated, and we have to deal with them. I've been lucky, I think, to have Dr. Dewan was one of my mentors. He's the president of our hospital system, and so lucky to have some relationships in places. So again, it comes back to collaboration and relationships, and that people, and one of the ways we have to use our influence is, the hospital systems love these programs because they're great PR. They love to put out, we're taking care of the poorest folks, we're vaccinating folks, we're going out to them, so then when the time comes and I need money, I say, look, we make the hospital look great, now help fund us. So I don't have any staff. Right now, my staff was overwhelmed and they were all out ill last week. So I was doing data entry for the COVID vaccinations we did, which is fine, but it's not the best use of physician time. I could have been vaccinating more people instead of doing data entry, right? But, when the time comes, we just say, look, we're here doing God's work and we're asking for some funding to at least pay for some administrative staff or another nurse practitioner to help out. But yeah, funding is a complicated issue, but we have to I've become more and more aware of budgets and the need to meet them and get funding, for sure.
Yeah, thanks. Tsitsi in the chat had mentioned that they would love to hear more about the role of spirituality for health and recovery.
Right. So, there are two levels of it for me. One's my personal experience, and that, like everyone else, I'm human. I've had a lot of problems in my life and things I've had to work through. I've had a ton of therapy, and I eventually found 12-step groups. I went to one 14 years ago through my training, actually, and I found the model to be very helpful for my own personal emotional recovery. And 12-step groups are based in spirituality, and so there's, again, not religion. It's not a Christian group. It's a spiritual group. And so people can come and believe whatever they want. Some people say God is get outdoors, or their higher power is the group, or their sponsor, or somebody other than themselves, so they can see another viewpoint in their life other than their own thinking, which often got them into addiction or serious mental illness, where they're emotionally so depressed that they just feel immobilized. But so we want to respect everybody's spirituality, from atheism to evangelical, whatever, and recognize that spirituality is one of the most powerful tools for people to become emotionally sober, or sober from an addictive behavior. It could be sex addiction. It could be relationship addiction, or codependence, for example. You can't live without a girlfriend, boyfriend. Many of us here probably can think of somebody they know who just can't be alone, right? They always have a partner. They can't be alone. And often, again, this stems back to adverse childhood events. And we have all these wonderful biological tools. We have medications to help with depression or schizophrenia, and we can help with alcohol detoxification and opioid detoxification and opioid use disorder. And that's fine. We need to use those biological tools. We have psychotherapy, which can help people as well. But there's a spiritual aspect to particularly addiction treatment in the 12-step groups, but other forms, not just 12-step groups. But spirituality is a powerful force for recovery. And psychiatry is often known for atheism and for having the highest group of physicians who are atheists. And so, we talk about how, atheism should be accepted just as evangelical spirituality should be accepted. People have to come to their own understanding of a higher power, whatever that is. And then we as physicians or healers and wounded healers as we are, should be helping to encourage spirituality, because it is just such a vital part of recovery for so many people.
Thanks. With recovery and questions like that, Amanda had a question of, how do you define a recovered schizophrenic?
Right. So the difference between recovered and recovery is that, like with substance use disorders, often mental illness, you are never recovered. You are in recovery is how we would talk about it. I think, there's symptomatic and functional recovery, like we talked about. Your voices or your depression can be helped with medications and psychotherapy and other aspects of, meditation, mindfulness, etc. But that doesn't necessarily mean you'll ever be recovered. I don't think, one way of thinking of it is we're all in some kind of recovery, I think, if we're honest about it. I mean, I'll say I am, there've been traumatic events in my life and I'm still recovering from them. And I don't know that I'll ever be recovered, but I'm in recovery. I go to my 12-step group, I go to see my therapist, and I share with my partner, etc. But so I think thinking of it that way, that schizophrenia is a lifelong illness, just like humanity is a lifelong experience that many of us have. We will lose parents, we will lose other loved ones, we may be divorced, we may suffer through the death of a child, etc. And how do we recover from those events? Well, we participate in a program of recovery, and that can look very different for many people. Schizophrenia is a wide range of disorders and symptoms, signs and symptoms. Some people have, once they get things under control, they have minimal to no symptoms. Others will have symptoms for the rest of their lives. And then most people are kind of somewhere in between. And so people come to understand their recovery as what it means to them, not what it means to me. That's not really what this is about. Recovery is about what it means to each individual person. And then my job as a physician is to help people reach their goals. So that's, how I think of recovery. You're not recovered, you're in recovery.
No, that's great. C had some questions for you and says thank you for your lovely presentation. They asked, do you have any comment on the for-profit prison system and its downstream effects?
Yeah, so this is great. So Alexander talks a little bit about this in her book, and I've read about it a little somewhere else. So again, I'm not an expert, but my understanding is private prisons actually make up a very small number of prisons. But what is much larger is the privatization of the prison system. So for example, private prisons themselves don't make up that many prisons and don't hold that many. I mean, there's still a significant amount, but nowhere near the entire, the 2.3 million people who are incarcerated are not mostly in federal prisons, but they are in heavily privatized prison systems, meaning the canteen. So you want to get some food or make phone calls, you're going through private companies, and they price gouge you because you don't have a choice. There's no market, and so this is another form of control and how to keep people in poverty, stuck in poverty, and if you look back over the past 400 years, slavery, Jim Crow, and now mass incarceration and deportation. That's the argument that Alexander makes, is we just found different ways to control people that, that's just so upsetting. And we don't have time to cover all that today, but yeah, so my quick answer is private prisons, absolutely a problem. The outcomes are terrible there, but there are a small number of people in private prisons, but the privatization of services within prisons has been another form of control and keeping people mired in poverty.
And based on your description, they also asked, where do you see a role for public health practitioners in this role?
It's great. So I wish our country had a functioning public health system. Number one, it would be nice to have that. I mean, it's just obscene to me that we don't have a functioning public health system. This has been the result of the past 40 years of neoliberal budget cuts. We need to give, corporate tax cuts to, local big box companies instead of focusing on developing a public health infrastructure. And you see the result of that. We are at the second year, at the end, at the end of a second year of a pandemic, where nearly a third of the population, more than a third of the population, doesn't want to be fully vaccinated. They don't trust the government. They don't trust corporations. They don't trust the system because people have been neglected for so long, and the government's been left in such underfunding and disrepair that, I go door to door in the inner city and talk to people who don't have any interest in a vaccination. And it breaks my heart. These are my people, the people I work for, to try to provide mental health, substance use disorders, and they don't trust. They think I'm there to put a microchip in them or, to experiment on them, et cetera. My girlfriend's Black, and I told her I enrolled in the Pfizer trial, and she's like, "You trust those people?" And I just said, "Honey, like, we're in the middle of a pandemic. Like, this is our one way out. I'm either, maybe I'll die from this vaccine. I never believed that, but it's already gone through, layers of trials. But this is our way out, or one of them, a big part of it. But it's, I'm sure this must be Chris Morley, who's the head of our public health program at Upstate and does great work. But, he's right on here asking about privatization of prisons and public health. These are two of the most critical areas for the future. And I hope I'm sure some of you probably already are involved, but some of you will look at these systems. How do we advocate for and fight for a public health system that we deserve in this country? And how do we get privatization out of so many areas of our life that it's just destroying? If the point of life is to make a profit off everything, what does that say about our basic nature and sense of justice and fairness? It just is. Healthcare is probably, the top of the list for me. We need to move towards single payer healthcare. and cover everybody and not worry about, huge salaries for physicians, for example, and administrators, the administrative costs. We need to talk about what our real values are and what we want for everybody. But again, these are longer discussions, and I see we're down to our last 3 minutes here. So what else can I answer on the list?
So Phyllis had a question on how are peers identified? Is there peer training?
Yes. So peers are self-identified, right? So if I say I'm a peer, I'm in recovery, and then there are trainings and certifications available. And like I mentioned, these are extremely valuable folks, programs, and tools in reaching some of the most hardest to reach people. But yes, peers would self-identify, get training, and then would be hired to work in programs, or like in a 12-step program. I mean, I'm in a 12-step program. So I identify myself as someone who comes from a dysfunctional family and acts, has adult child traits and is in recovery from them and working on those. So those would be different ways peers identify themselves, and I get training by going to my 12-step group, and then I sponsor somebody, and I hope one day he'll sponsor others. And that's a little bit about peers.
That's great. I had a question sent directly to me that was on top of COVID and your work in COVID, there are hundreds of people being evicted and the foreclosure moratorium expiring. So with that, how do you see that impacting your work, the health community, especially knowing the majority are impacted at low income?
I'm sorry, I missed it. So this is about the impact of?
The COVID's impact on like tons of people being maybe evicted because of lack of jobs and finances and things like that, and the foreclosure moratorium expiring, things like that.
Yeah, I'm sure many of you have gotten the flavor coming from me, but many cities just ban evictions. I mean, it just is, it's in my mind, it's very concrete and simple that, and that doesn't mean abandoning landlords. Landlords need to be supported as well. Their job is to, to pay their bills through giving housing. So again, if we invest in the appropriate structures and systems, if we had basically a functioning government that was used to helping people and providing services in a streamlined way, instead of all of a sudden, we treat the government like it's just chronically underfunded while we're funding corporations. And then a pandemic hits where we suddenly realize, oh yeah, people are going to start dying, starving, and being out on the street if we don't do things correctly. And of course, administrative systems are totally overwhelmed. So we have to take a long-term look at these of how we want to restructure our society and treat each other. And that's going to cost money, and I think the Biden administration is starting to do that. And it looks really appealing, a number of the things the Biden administration is doing, but that's still probably just a fraction of what we need. And we need a long-term investment. If we do 4 years of Trump-style governments, I mean, it just is devastating to everybody. I see we're out of time. I'm happy to hang out for those who want to, but don't feel obligated. If you want to go. People can always get a hold of me otherwise, but I'm happy to stay and do a couple more questions during the break if people want.
I'm sure Nadia will cut us off if we need to go. There was one more question, and it was, has the multifaceted ACT framework been utilized to treat pediatric populations? If so, how does that effectiveness compare to that in adults? Are there any challenges to its applications, pediatric versus adult?
It hasn't that I'm aware of, no. And that's, it is so concerning. I have one patient, he's like 18, and I go to see him and his mom, and he has 6, 7 siblings, and the kids are running around. Mom's trying to do her best, and I leave emotionally overwhelmed, and I can't imagine what it's like for mom and for my patient. He has schizophrenia, so he's already suffering, and he thinks the answer is cannabis. That's going to solve his problems, and I'm trying to tell him cannabis increases psychosis, but that's not his experience of it. So you can see that this is the complicated nature of the work we do. Desperate poverty, chronic mental illnesses that affect your brain, addiction that's probably making symptoms worse. So the nature of the work is difficult, and we don't have specific programs for kids. The pediatricians, God bless them, do this every day when they, try to do their best to meet the needs for the families, so social workers, others. adult, Child Protective Services. People cringe when they hear that name, but the purpose of Child Protective Services is to add layers of service to people in desperate need. So it really, it's seen as punitive, and often can be. I mean, some of the stories sometimes are really upsetting, but we have this fragmented system that's supposed to provide support, and we need all of you to continue to build it, advocate for it, and do the work for, from the littlest ones to the eldest. We need to do a much better job at taking care of each other, our community, and then training folks. That's what I want to do, is train people who want to come along and do this work and learn how to do it, and then do it themselves.
Nancy had a question that, are you working with refugees/immigrants, and what unique mental health challenges are you seeing in those populations?
Yeah, hi Nancy. So this is a big challenge. So I have one patient. She's from Burundi, so she speaks some English, but she has schizophrenia and she's an alcoholic. So she drinks to the point of having seizures. So she's in and out of the hospital. So we often cannot find her. So you think of the complicated nature of working with someone who doesn't speak native English, drinks to the point of blackout and seizures, is dying. She's young. She's about 35, and she's going to be dead soon because she can't stop drinking. And no matter what we try to do, she doesn't take her medication. So she's, this is the aspect of the work that's so difficult, is that there's nothing I can do. We're doing what we can, but I feel utterly helpless to disturb this pattern of behavior that she's addicted to alcohol. It's taken over her brain and it's killing her. And, I don't know what else to do. And, we don't really have time today to cover the interventions we do, but we do work with refugees, and often they come to us. Many of them do quite well, honestly. If they have the fortitude to get to this country and escape what they've escaped, they often have the emotional strength to get out of desperate poverty and get some kind of employment or education, learn English as a second language, or they may already know English. But yeah, refugee work is very difficult. And it just, again, emotionally, I just start to get sad when I think about her right now, because my expectation is within 6 to 12 months, she'll be dead. I mean, she's having gastrointestinal issues, and the seizures themselves show the brain is in end stage. Right. When we're always looking at what's going on in our end organs. How are our organs functioning? I'm not urinating. Oh, that's not a good sign, right? You can't think clearly. Oh, something's going on with the brain. You're having seizures. The brain is sending the message, don't drink anymore. You are killing me with this. And my expectation is she'll be dead within 6 to 12 months. It's very difficult.
Not to end on such a dark topic, but we do have to proceed to the next groups. Thank you so much, Dr. Islam, or Sunny, sorry, your father's not here. And thank you so much.
Thanks for having me.